Okay, good morning. We're ready when you are.
All right, excellent. As a reminder, please make sure you mute your audio unless you have a question, or you can put it in the comment chat section. And I'll look for the chat on my phone as well. But this is November case reviews, and we've got a couple cases that will hopefully highlight some information that will improve your practice or that you're already doing in your own practice. So starting off, this information is confidential and privileged, and that you are not allowed to distribute or copy it. It's strictly prohibited in respect to the HIPAA laws. So moving on, case one. And is Dr. Whitwer, I don't see him on.
I'm on.
Oh, okay. I don't see you on the chat list, but perfect. Because
for some reason, as I've been excluded from the chat.
Oh no, but good news is that the first case and the second case are going to be the ones that I think that you wanted to give your further perspective. So, so case one is a case of an 83-year-old female. EMS was dispatched to ineffective breathing. Their PPE usage was appropriate for the situation. And they found this patient to be unresponsive. Her airway was open, but she wasn't protecting. She was pink, warm, dry, pulseless, but there was no signs of active bleeding. Vital signs were obtained within the first 2 minutes of patient contact. She had no pulse. A blood pressure was not taken. Respiratory rate was not indicated, but assuming this was 0. Her GCS was 3, and of note, this is a elderly female at 36 kilos, so she's pretty tiny. Past medical history is that she's a diabetic, she has hypertension and hyperlipidemia. Witnesses, her granddaughter had found her to be cyanotic with no chest rise, and sounds like it was pretty early on in her arrest that her granddaughter found her this way. Bystander CPR was initiated, and that the granddaughter reported that she didn't know what her DNR status was, but she was a hospice patient. And in this particular case, fire was on scene for a pretty prolonged period of time prior to transporting agency arrival. So under treatment here in the first bullet, fire care was initiated with CPR, iGel, and then 2 attempts at an IV. Transporting agency arrived 9 minutes after first EMS contact. So approximately a 13-minute downtime. An IO was placed and she was given epi. The son was at some point present, and although with a language barrier, he also confirmed that she was a hospice patient. So epi was given at the 5-minute interval, and the transporting agency informed the fire department that they were searching for her advance directive paperwork as they continued to attempt to resuscitate her, and that AMR ended up contacting hospice directly. And then online medical control was contacted based off of the conversation with hospice, stating that she was not only a hospice patient, but that she also had a DNR. Online medical control was contacted between probably the 6 and 9 minute interval, where they were given the okay to stop resuscitation. When they returned to the patient, she was being shocked for this rhythm of VTAC. And the patient was still in cardiac arrest. This is a little bit confusing from the conversation that I spoke with one of the agencies, that they had actually said that they were continuing CPR, and when they came back to the patient, she was being shocked and they actually got a pulse. But anyways, so at that point, she regained pulses at the 13-minute interval. She ended up having a heart rate of 91, a blood pressure of 133/113. A respiratory rate was not obtained. Her SpO2 was 88% and her end tidal was 33. They waited for a little bit longer to see if she was going to trend back down towards imminent arrest. It didn't appear to be the case. So at the 19-minute interval, they started transport and they notified the hospital as a cardiac arrest alert. They obtained a 12 lead at that point, which is this. Pretty poor in quality, probably regarding to the fact that they were transporting, but a lot of artifact in there. But you can see that there's an organized rhythm that is not regular. That's interpreted by LifePack as as AFib. You can tell that at least in lead 3 of the cleanest lead that we have besides V2 and some of the lateral precordial leads is that it looks like there might be some ST elevation, which might be why this EKG is interpreted by the machine as a acute STEMI. After 1 minute, as it would probably seem to always be the case, is that she rearrests. And so they already know she's a DNR. They already know that they've already talked to medical control who's pronounced her once previously. But given the complexities of having this patient be called in their ambulance while they were transporting her, they elected to continue to resuscitate her. So she ended up getting CPR at 7 minutes after she rearrested. They got pulses back again. She was very tenuous, hypotensive at 77/50, heart rate of 67. No respiratory rate was documented, and her SpO2 was 72%. She had an end-tidal of 27, and blood glucose was checked at that point, and she was 452. A 12 lead was repeated, which is largely unchanged from the previous 12 leads, so I'm not going to go over that one again. And then she rearrested a minute after she got ROSC. They gave her epi, and they arrived to the hospital. So, in just looking at the pre-hospital care, good here is online medical control was contacted after contacting hospice. An end-tidal CO2 was obtained 12 leads serial when she got ROSC back, and then completeness of finishing up with a blood glucose. With the decision to treat her with ACLS care, I don't see any major issues, but where we could really improve here is the time it took to contact hospice. It's documented in the fire chart that the granddaughter had notified the pre-hospital crews that she was a hospice patient pretty early on, and it took over 9 minutes to get a call to hospice or to search for her paperwork, in that we are doing ACLS care for her in the interim. And then multiple attempts at resuscitation prior to and post online medical control. So if I understand that, or at least I'm being told, which is not uncommon in other agencies I've been affiliated with, is that if we stop CPR in an ambulance, that ambulance is out of service and either processed as a crime scene or at least processed for body retrieval with the medical examiner's office. So if you're transporting and you've waited a decent amount of time on scene for a DNR patient who's regained pulses, that I think BLS care, which BLS care would be appropriate, not a slow code or whatever other term might be used, but BLS care until arrival to the hospital, and then they can immediately call it. So in the emergency room, CPR was resumed after confirming with family that she is indeed a DNR and a hospice patient. So resuscitation was terminated shortly thereafter. So Dr. Whitworth, this case, I was going to do more discussion of hospice, but I think the second case, unless you have specifics about hospice, the second case is going to be one that you can elaborate on the recent changes with the state of Washington. Right. So hospice is a philosophy. It's treating the patient, not their disease. So it's really making them as comfortable and having as much meaningful life as possible that they have left. And then it provides the patient who have a life-limiting illness and no longer want to pursue treatment or care, or treatment to cure, just to be comfortable. Typical life expectancy for a hospice patient is less than 6 months or substantially less than 6 months. So upwards, the longest projected life would be up to 6 months. In that the patient makes the decision to enter hospice. It's not the cares members. It's not the family directly, unless in certain circumstances, and it's not the hospital crews or staff. It's the patient that makes that decision if they have the ability to make it. And there are no limitations to who is eligible to be in hospice. This can be a pediatric patient. This can be an adult, an elderly patient, which I think all of us are aware of. This is more just kind of like for the general lay public, and that a person that anybody can be eligible to be hospice, but there's a caveat. It has to be a physician certified that they have a disease that has a time course that would lead to their demise within the imminent future, up to 6 months. And so they have to have a disease, they have to have less than 6 months to live, and it has to be certified by a physician. Although that might have changed, I don't know. This is from the state of Washington, but it might have changed in that advanced practice providers or NPs might be able to, NPs or PAs might be able to also certify, but at least what I found on the Washington website is it has to be a physician. And then all hospice programs have a 24-hour, 7-day-a-week, basically call service that you can contact them and get further clarification, especially in cases like this. This case, I don't believe occurred in the wee hours of the night, but anytime that you're in a situation where you have a hospice patient that you are considering doing advanced procedures or ACLS care on, and you're not getting information from the patient, you can contact hospice to get clarification on what the patient's wishes were. Any additional information that anybody on this call would like to add, either a personal experience on this call or in their own practice, or just knowledge for the group?
Just a point of, essentially, when you elect to go into a hospice program, the patient, and therefore the family as well, has given up their rights to make medical decisions. That's all. Medical decisions are made by hospice at that point. And so if they're in a situation where they're wanting to be transported to the hospital because of pain or something like that, you would contact the hospice program and discuss that with them. I mean, you can still give a hospice patient palliative care, pain medications, etc., things to make them comfortable, but they have essentially, they even though many of them have Medicare or Medicaid, they don't really have it. When you go into hospice, you sign over your Medicare, Medicaid insurance stuff to the hospice program.
Thank you, Dr. Whitmer.
And so you can revoke hospice, but without revoking hospice, everything that Dr. Whitmer says apply.
It's not. I'm going to talk about pulse later on, but it is possible to revoke pulse right at the time. It's very hard to revoke hospice.
Agreed.
All right, thank you for those points, Dr. Whitmer and Dr. Mott. So on for the second case of a 95-year-old male. EMS is dispatched for respiratory distress to Memorial Urgent Care. PPE was appropriate, and the assessment is that this patient is awake. His airway is open, he's protecting it, but he is in severe distress. He's cyanotic to the lips and the nails, he's clammy, he's dry, and vital signs upon initial patient contact were notable for a heart rate of 114, a blood pressure of 97/49, a respiratory rate of 31. He is about 81 kilos. In his past medical history that was documented in the pre-hospital chart was that he has a history of hypertension, hypothyroid, and hyperlipidemia. He lives at a care facility, and actually adult foster home. And he has been having shortness of breath for the last 2 weeks, which has been progressively worsening, as well as congestion. He has audible growls and rhonchi, and he was seen in the emergency room the day before. I didn't see that encounter, so it might be somebody's not using Epic. But anyways, in that upon arrival to the with EMS, the patient had indicated that he wanted to revoke his DNI comfort measure status. So at that point, the urgent care staff had him on a 6-liter non-rebreather mask. They find this patient in moderate to severe respiratory distress with pursed lip breathing, tripod position, 1-sentence dyspnea. He can't even communicate with words, so he's just using his hand and his head to respond to yes and no questions. They started him with 5 milligrams of albuterol and 0.5 milligram of Atrovent, and placed him on CPAP. At the 9-minute interval, he's still tachycardic. His blood pressure has improved. 128/52, respiratory rate of 26, and GCS of 15, and a SAT now of 93%, Untitled 35. They document in their narrative that they held nitroglycerin because, and I'll explain that a little bit better. They weren't sure if he was a primary respiratory problem, pneumonia. They were also concerned about heart failure. They noted that when they first placed him on CPAP, it seemed like his pressures had dropped, although the ones recorded here don't show that it dropped prior or post CPAP use, but that was their documentation and narrative. And so although they were considering heart failure, they held the nitroglycerin, worried that he would become hypotensive too quickly or rapidly for him. So they placed an IV 14 minutes after arrival, and another set of vital signs shows continued tachycardia, stable blood pressure, and that's another small pet peeve of mine is one set of vital signs is not stable. You have to have serial vital signs. So stable blood pressure. He's still tachypnic at 32. SpO2 is 96%. End-tidal CO2 is 35. Blood glucose is normal. They get a 12 lead prior to leaving urgent care, which is this 12 lead, narrow complex sinus tachycardia, no other arrhythmias noted in that. And one more set of vital signs, still heart rate of 114, stable blood pressure 118/56, respiratory rate has decreased to 24, and his SpO2 and end-tidal are largely unchanged. They initiate transport, another set of vital signs, and they arrive at the hospital. Now, they document that they switched the patient off of CPAP to non-rebreather to comply with hospital wishes or protocols. I don't know if, I believe that has actually gone away. If the patient needs positive pressure ventilation, then they get positive pressure ventilation. But in this particular case, the patient was roomed in the hallway, and we just physically weren't able, which, you know, in this particular case, it was helpful because the patient was back on non-rebreather, and we wouldn't have been able to place him back on CPAP because we had no rooms and he was in the hallway. Although that plays into it later. All right. So in reviewing this case, I thought the documentation was pretty solid. Discussion of code status and justification of the patient's mental status. The crews documented that the patient was, although in distress, in extreme respiratory distress, that he was lucid, he seemed to be absolutely appropriate, and that there was no reason to believe that he was hypoxic or confused, stating that he wanted to revoke his code status. Medical management, including consideration of holding nitroglycerin if you're concerned of a patient having a tenuous blood pressure. They had documented their differential diagnosis. They repeated and obtained complete serial vital signs, and they also were complete in finishing up this management with a 12 lead. Ideally, within the first 10 minutes, if you're going to get a 12 lead for possible cardiac and respiratory, especially if this patient ended up having a STEMI, but nonetheless obtained. And I really didn't see any areas for improvement in my review of this case. So in the emergency room, I took care of him. His history was a long-standing history of DNR, DNI comfort only, but again, he is requesting to be a full code. He was not COVID vaccinated. We had probably an hour of sitting in the hallway trying to get him his own room so we can put him on BiPAP. Because the non-rebreather really didn't seem to be, it seemed like he was becoming even more tachypnic and more obtunded. They couldn't get a rectal temp because he was in the hallway, but he was tachycardic, tachypnic, hypoxic, and hypothermic based off of a skin temp. So he was upgraded as a sepsis. Antibiotics were ordered and IV fluids were held due to concern for, again, heart failure. And once he got roomed into his own room, he was placed on BiPAP. During his hospital course, a CT-PE pulmonary embolism scan was obtained, and he had a right middle lobe infiltrate concerning for aspiration pneumonia, a small effusion, and unbeknownst to us, a small right pneumothorax. Because of that, we took him off positive pressure ventilation and placed him on a non-rebreather mask. At this time, it was kind of a conundrum. We have a 95-year-old who is in his own right in extreme respiratory distress, concern for sepsis, and now has a pneumothorax. It was measured to be about 10%. So going back to him, talking to him about the fact that normally we would consider putting in a small pigtail catheter to help reinflate his lung. He elected to hold on that and to do serial chest x-rays. In the event that he needed the chest tube, he would accept it. So just a case from going from zero DNR DNI as in aggressiveness to almost fully aggressive at this late stage in his life and extreme acuity. On hospital day 2, there was a long conversation with the hospitalist talking to him about the goals of care, in that the probability of him surviving even aggressive resuscitation, or if he would be intubated or to have CPR. And in light of that discussion, he decided to go back to DNR, DNI selective. He wasn't ready to be comfort only. And then on hospital day 3, he kind of changed his mind fully, and he said that he wanted to be comfort only and wanted to go back. Hospice was consulted, and he was discharged back into his adult foster home or family home on hospital day 7, where he had passed away. So a little history about do not resuscitate orders. Interestingly enough, CPR, and Dr. Whitmer might be able to shed some additional light on this, but according to what I was able to find in Washington's DNR information, specifically from UW, was that in the 1960s, CPR was initially performed by anesthesiologists who had witnessed cardiac arrest both on pediatric and adult patients. And because of such good outcomes with this witness CPR, that it became the standard for all patients, not just our operative patients. And then in 1974, American Heart Association, seeing that the patients that received CPR oftentimes could have significant morbidity, had recommended that we as in healthcare providers document in our charts that when a patient decided that they did not want resuscitation, and that's kind of where DNR became, I guess, more of a entity that got coined with the term DNR. So does anybody know differently about the history of CPR and DNR?
No, that's pretty accurate. The first external defibrillators were developed in the late 1950s, early 60s, and they were not portable. The first portable defibrillators came about in about the mid Well, the late 60s. I know when I interned at Hennepin in Minneapolis in 1968, we had two defibrillators in the entire house, one in the emergency department and one on the medical floor, and the whole test to be on that cardiac resuscitation team was you had to be big enough to push the machine around because it weighed about 250 pounds on wheels. And it was AC, you had to plug it in and had a DC converter. At any rate, we were doing CPR, but the problem with DNR, the problem with CPR in those days is that we did resuscitate people, but often resuscitation got a very bad name because people were vegetative for a long time before they died. The history of the actual development of CPR is quite fascinating, but that's not appropriate for today.
No problem. Thank you. So the next thing is patient autonomy, respecting that the adult patient has the right to make their own medical decisions, and that was reinforced by the Patient Self-Determination Act in 1991. And then when the patient cannot express their wishes, there's a legal hierarchy of surrogate decision makers, and it goes in this order. So legal guardian with healthcare decision-making capabilities, individuals with durable power of attorney. The third one would be the spouse. The fourth would be adult children, but they all have to be in agreement. And then it goes on to parents of the patients. And then lastly, adult siblings, but they all have to be in agreement as well. This is probably a good time, Dr. Whitwer, if you wanted to talk about, I have our Southwest Region Protocol review here on Do Not Resuscitate, which goes into a little bit of the living will, the pulse, the DNR. If you wanted to add additional information about the new changes.
Well, the new form, I'm not sure I can bring it up here now. I have it on my, now, how do I do that? I guess I have to go to.
I think.
Oh.
I think I'm gonna have to get out of sharing. And then I think now you can share.
Okay, let me see if I can share. See if I can get what's on my desktop to come up. I've got a spinning ball of doom going on here.
If you want to send the link or the image to me by email, I can pull it up and share.
Yeah, that's probably going to be quicker because I'm just doing the spinning ball of hell here. Let me bring that up and I'll. Okay, let me get to this and get to. It's on its way.
Okay. All right. And perfect. So let me just go back to sharing.
I think you can see that for EMS the confusions for on DNR and power of attorney and living wills and all that sort of stuff is because there's just so much of it. Now the we've been trying, originally back in the 80s, we developed, with the help of the WSMA and the Department of Health, we developed the EMS no CPR, which preceded the pulse forms. And this was basically instructions to physician instructions to EMS based on a decision between the patient and the physician that which expressed their wishes in the form of an order to EMS, because barring a direct order from a physician or physician assistant or now a nurse practitioner to EMS cannot make, they need a physician's order to terminate resuscitation attempts. And without that, we were required to always do, we have the duty to act, so we would be required to do everything we could to try to resuscitate the patient. Now, EMS no CPR form was pretty good. It was reasonably accepted. Washington State, mostly through physicians in Spokane, thought that it would be better to have the PULSE form, which in those days was called the Physician's Order for Life-Sustaining Treatment, i.e. PULSE. And that went along pretty well, but it slowly started getting getting everybody involved in the care. And this was really designed for EMS. But the various and sundry nursing situations started getting it. The hospitals thought, oh, we could do a shortcut to making changes in the orders in the hospital, but that is not really true. Now, so over a period of time, we've been wresting this back to being primarily for EMS. I was on the committee in the last 2 years that we revised the PULSE form. So this is the new form of PULSE. Now, PULSE is not the same as a living will. That's something that's done with an attorney, and it has very little medical connection, but it does express in terms of the patient's long-term goals. And if there's a power of attorney, the power of attorney can then use that information and inform EMS and inform the hospitals and physicians of the wishes of the patient. However, it doesn't count the same as a medical decision. So if you have somebody or a medical order, if you have a patient who has a living will, and the living will says, and they show it to you, and it says that, well, he doesn't want to have resuscitation, then you contact medical control and relay that information to you, and they'll give you the medical order to cease or not resuscitation attempt. Now, when does the DNR order come into effect? That's only in a situation where where the patient is in a skilled nursing physician, because a DNR order is an order from physicians to a skilled nursing facility or skilled nursing personnel. DNR orders do not have any weight in a family, in a adult foster care, because there are no skilled nursing persons out there. They need a PULSE form to make this simple and work. And it's been the bane of many of us for a long time, is that it's like pulling teeth to get people to do PULSE forms. Well, here's the new PULSE form, which, and the only important thing about the PULSE form that you guys need to worry about is to look at the first page. We made everything that it has to do with EMS on the first page. We'll go to the second page, but it's got stuff. Don't worry about it. So the first page is what you need, and So it has a new logo, and now they call it portable orders for life-sustaining treatment because some of the other, it's no longer physicians only that do this. It's physicians, physician assistants, and nurse practitioners. The chiropractors wanted to get on the action, but said, well, you don't do CPR and you don't do resuscitation anyway, so that's not going to happen now. It has the pulse form is pretty much, it looks pretty much the same, last name, first name, middle initial. Also has the required optional pronouns and genders nowadays. Cardiac arrest, it doesn't seem to make any difference to me. Now, the first thing, we made it number A, because it used to be down the line. Use of cardiopulmonary resuscitation when the individual has no pulse and is not breathing. In other words, they're in arrest. Yes, attempt resuscitation, or no, do not attempt resuscitation. Allow natural death. Now, so they also have to choose full treatment in section B if you say attempt resuscitation. That's the deal. We don't say, oh, you can have everything except we can have medications and IVs, but we don't want to be intubated. No, if you want us to attempt resuscitation, we have to use the full meal deal. When they are not in cardiopulmonary arrest, and that's important, is that a lot of times you will get out there and they have a pulse form, but they're not dead. They're having respiratory distress, they're having pain, whatever, and you can treat them. Do not resuscitate does not mean do not treat. That means do not resuscitate, plain and simple. So what a person can do so they go to number B then to pick what level of medical intervention they have, even if this says do not attempt resuscitation if they're dead, if they're no pulse and not breathing. So they can pick full treatment, which is unlikely if they said don't attempt resuscitation, but in selective treatment, treating medical conditions, so you can use IV fluids, medications, cardiac, but don't intubate if they want selective treatment. They can have less invasive support, such as CPAP, BiPAP, etc., high flow oxygen. If it's indicated, transfer to the hospital if indicated. And we will try to avoid intensive care in the hospital if they have selective treatment. But everybody can have comfort-focused treatment. The primary goal is comfort. So they can use oxygen, oral suction, manual treatment of airway obstruction for comfort. The individual would say, I prefer no treatment to the hospital. If treatment's indicated, talk to medical control. And then there'll be additional orders. There were a whole bunch of that really has nothing to do with EMS, but we had to give it a couple places, and so we said, okay, now the signatures all have to be there, and the signatures have to come either from the patient or the guardian with healthcare authority or a legal healthcare agent, designated power of attorney for healthcare, or another medical decision maker, and that's all within the RCW. It has to be signed by the MD, DO, ARN, or PAC. Print the name. Individual legal medical decision makers have to sign it and the relationship, and it has to check the boxes whether they have durable power of attorney, healthcare directive, living will, etc., etc. And that original form should go with the patient whenever time. But here's the beauty of the new pulse form is and I'm telling all the patients who have them and all the people who have them and all the power of attorneys, get a picture of this on your iPhone and you can send it in a moment's notice to EMS. You can send it to the hospital. You can send it anytime. Oregon has a much nicer relationship. They have a pulse registry, And you can, if it's an Oregon patient, you can call the pulse registry, and within 1 minute, they will tell you if they have a valid pulse form. But a picture of this, a copy of this, I suppose a line drawing by an artist would also, but anything documenting this is acceptable now. You want to go to the second page just to show it. Okay, second page has all sorts of stuff, and none of this applies to you. So don't even pay any attention to it. You take it in when you go to the hospital and give it to the doc, and they can do that sort of stuff. So the front of the page, the front form is the only part that you need to worry about. Now, we'd like to see as many, unfortunately, and people still have the right, the person has the right to rescind the post form at any time. And just like this case, people who are short of breath, that's the most scary thing for anybody at all. So they often rescind it. And families will rescind it. They say, we have, they have a DNR order, they have a pulse form, but we want you to do everything. Don't fight with people on the scene. But the first case, generally speaking, when you're in to my knowledge, I've never seen a person in the hospice who didn't have do not resuscitate status. That's the whole point. Mm. It's comfort.
And so typically when we're entering someone into hospice, we'll complete the pulse at that point if they don't already have it.
Yeah. And Jackie, the real takeaway on that first case is to make early contact, if there's any question, to make early contact with the hospice program 24-hour telephone line.
And exactly, and in our Southwest, or in our Clark County protocols, under guidelines in that bottom right box, BLS protocols we've followed while attempting to determine if a written pulse form, DNR order, or living will is present. So in an effort to suss out that patient's advanced directives, especially if there's a question to if they would not want heroic measures, do BLS until you can confirm or deny that they have a code status that is confirmed by either their power of attorney or their hospice coordinator or hospice call service.
We're going to upgrade our do not resuscitate orders a little bit to include the discussion of hospice in that, so that there's more specific direction. I can see in the middle of the night, we have to make these things less confusing. The thing is, there's no one single number, so you have to get the number for, there's several different hospice programs, so you need to get the number of that patient's specific 24-hour telephone number, but the family has to have that.
Mm-hmm. Absolutely. Thank you, everybody, on the additional information for this case. Anything else before moving on to the next case? All right. So this is a case of a 23-year-old short of breath. PPE usage was maximum. They found this patient to be unresponsive. Her airway was open. She was labored in agonal respirations. They noted that she had skin that was pink, warm, and dry, and there was no evidence of bleeding. Vital signs obtained was approximately 6 minutes after patient contact, which the only two that was recorded was an SpO2 of 86 and end-tidal CO2 of 80. Her past medical history included asthma, and the story that they were given was that the father heard a large commotion or a bang, which he attributed it to her collapsing, and so he called 911. and that the additional information was that she was a marijuana user. So 3 minutes after patient contact, IV was attempted, which was unsuccessful. They gave 2 milligrams of IN Narcan. At 6 minutes, they started ventilating her with an eye gel and a bag valve mask. It's noted in the narrative of our EMS crews that they were able to ventilate her well with the eye gel. Her SATs are the first ones that were reported in the previous page, and the end title was elevated at 80. I believe there was an access was obtained in interim between the last IN Narcan, so they were able to give IV Narcan 2 milligrams, still no change. They checked a blood glucose at 10 minutes after patient arrival, and the repeat SpO2 and end tidal CO2 was notable for an increase to 97%, and then end tidal had also increased at 84%. An IV, I believe a second IV was established, and it was noted in one of the crew's documentation that the patient became awake. She started yelling and crying and stated that she could not breathe. She ripped out the NPA, which wasn't documented in the procedures, but clearly she was able to have the wherewithal to pull out her NPA. It's documented that the patient woke up and was kind of biting down on the eye gel. So apparently she not only pulled the NPA, but the eye gel got removed so she could actually talk. And then decision was made to RSI versus DSI. It's a little between the two agencies. One documented DSI, another documented RSI, but she received 200 milligrams of ketamine at 23 minutes. And then attempts at ventilating her were initiated. She had succinylcholine given to her 5 minutes after the ketamine. An IO was previously, or an IO was placed at the 29-minute interval, but it got yanked or pulled, and the patient was attempted to be intubated. It's documented as 3 attempts. In front, I can gather between the 2 charts. 2 attempts were made early on where they had difficulty in placing the ET tube with due to heavy secretions and vomitus. So an eye gel was replaced. They initiated transport 35 minutes into the case, and the first full set of vital signs are documented. Heart rate 110, blood pressure 158/110, respiratory rate of 10, and GCS of 3. At 39 minutes, she has another set of vital signs obtained. She's no longer tachycardic. She's still hypertensive at 164/139. Her GCS is 7. Her respiratory is 7. Her GCS is 3. And it's documented that her SpO2 is 29%. Her end tidal is 65, and the crew's attempt to change out her eye gel, and from what I can gather in the documentation, is that they thought a larger one might seat fully and prevent her from vomiting. And then it's documented in one of the charts that another intubation attempt was made at this 39-minute interval. So she's 10 minutes out from getting a paralytic and over that for sedation. And that is also unsuccessful. They gave her Solumedrol 44 minutes into the case. They document that she's profoundly hypoxic. They're trying to ventilate her with an eye gel and a bag valve mask. But because of the 3 previously failed intubation attempts, that they did not move towards intubating her again. And she arrived at the hospital at 53 minutes. So the pre-hospital care here, I thought the good stuff was PPE usage in general. They used a HEPA filter as well. They placed an eye gel really early on and were able to ventilate her well while they were looking to find reversible causes with use of Narcan and checking a blood glucose. They used PEEP. They documented PEEP was 5 and that they increased it to 10 while they were ventilating her further down in the care, but nonetheless increased PEEP. And then where I think that we can improve as a group in cases like this is if you're ventilating with an I-gel appropriately, you're getting sats up into the 90s, just sedate them off of that. You don't necessarily absolutely need to move towards intubating unless you're not able to ventilate them appropriately. And from what I can gather in the documentation, she didn't start vomiting until she didn't start vomiting until she was in the peri-RSI state. So back when 6 minutes into the care, if the reversible stuff is not reversible, 7 minutes in, just sedate her off of that, assuming that if you are ventilating her, increasing her SpO2 and blowing off her CO2, she's going to start to wake up. And potentially, you could just pull the tube if she really does wake up, or the I-gel, but I think in this case, you've got a person who's in imminent arrest that just ventilate them with your SGA or your I-gel and sedate them so that they can tolerate it. And then the decision to move forward with DSI or RSI, the documentation wasn't clear. At least I wasn't sure if everybody was on the same page of what they were moving forward to. And that they documented it as she was biting the I-gel and therefore they felt that she needed to be RSI'd or DSI'd. The I-gel works as an effective bite block. They really can't bite down and clamp that tube. And then they treated for reactive airway disease incompletely. No bronchodilators, just the solu-medrol. And in the documentation, one crew documents clear breath sounds. Actually, one crew documents clear breath sounds. The other crew doesn't document any breath sounds. So if you're worried about a particular disease process, having not only assessment but documentation in your chart to prove or disprove that would be helpful. In the emergency room, she was cyanotic. Her sats were 50. I talked to the doc who was taking care of her. They said that her lips and her around her mouth and her nail beds were gray. The doc and the respiratory therapists were dedicated to just ventilating her with a bag valve mask. And they got her sats up to 80%, which was the highest that they could get her sats up. They said that she had copious amounts of vomit around her mouth and in her airway. So they didn't think that they were going to be able to get her sats above 80. So they intubated her at 80% with a video laryngoscopy. Her initial blood gas was a pH of 6.9, a PCO2 of 93, and a bicarb of 18. Her lactate was elevated, and they treated her with continuous bronchodilators as well as sedation. She was admitted to the ICU. She was extubated, I believe, hospital day 2. Her father had told individuals that she was smoking pot. But the patient stated after extubation that she doesn't smoke, she only vapes, and that she vapes so that she can handle her anxiety. The pulmonologist was consulted during this hospital admission, and they felt that she had severe bronchospastic disease and that her vaping or smoking or whatever she was using caused her to have profound bronchospasms that were situationally related as opposed to having primary asthma exacerbation. And discharged on hospital day 4 with surprisingly no long-term sequelae for her hypoxia. They did note that in her chest x-ray that she had evidence of aspiration, which they just monitored to ensure she didn't go on to have a bacterial pneumonia. So I thought this would be a good moment to just kind of talk about I-gel versus ET tube. I think in general, ET tubes we think of as like preferred, as a definitive, secure airway. No one's really going to replace it unless there's some malfunction on the ET tube, if that's like the cuff leak or whatnot. But SGAs or our I-gels are really fantastic, and there's some physicians that either in the operative course or even in transfers from emergency room to admission, keep an SGA in throughout the entire transport, because if it's ventilating, it is oftentimes just as effective as an ET tube. So a little bit about the benefits of an iGel, not speaking about Kings or combo tubes, but iGels, is that the insertion speed is faster than an ET tube, hands down. That the leak volume is comparable to an ET tube, and I think it was like 15 mLs of water. They don't have a cuff, so you don't have to fumble with a syringe or worry about a pilot balloon issue. Because of its structure, it doesn't have as likely of a chance to have a kink or to be malpositioned. So there's less likely for it to be rotated. And you don't write main stem with an iGel. And that the composite of the mask itself is without a leak or without a tear, as like our LMAs can have a break in its structure if there's anything sharp or if there's weather extremes. When I was in Minnesota at Hennepin, we went to iGels because we were finding so many problems with either the combo tube or King rupturing under these extreme cold temperatures of our hypothermic arrest. So even if this is sitting in a ambulance cabinet or in a frozen patient's airway, they're not going to have a rupture of the mask seal, and that they work very effectively as a bite block. They're not going to bite and clamp that tube distal to the mask or the laryngeal mask portion of it. So just as a review of, I think, we could talk about DSI and RSI, and we had this month to talk about DSI and RSI in our PCEP skills, thanks to AMR and Vancouver Fire. But because of that, I'm just going to really highlight our respiratory distress as it pertains to asthma. If you feel that your patient is having a reactive airway problem, we should be treating them with bronchodilators, albuterol and Atrovent, Solumedrol. And if you think that they're profoundly in distress, we should be considering epi or mag if appropriate. And if they're awake and they meet the criteria for CPAP, consideration of placing them on CPAP. Anybody have anything to add? All right. Last case. 71-year-old female presenting with abdominal pain and back pain. This was from Kaiser Urgent Care. PPE usage is appropriate. They find that this patient's awake, her airway's open, she's protecting. She has normal skin and there's no evidence of bleeding. Vital signs are 10 minutes after patient contact, with a heart rate of 108, hypertension at 180/95, MAP of 123, respiratory rate of 16, no weights documented. Past medical history that was documented is alcohol abuse, hypertension, recurrent urinary tract infections, migraines, and GERD. History of the patient's presentation is 4 days of pain. She vomited 2 days ago, started vomiting 2 days ago, and went to urgent care. That's all that we have for the narrative on the patient's presenting symptoms. In fact, almost the entire narrative is just that line. So 5 minutes into patient contact, vital signs are obtained, as I presented to you in the last slide. An IV was established, a 22 gauge, and her blood glucose was checked. At 20 minutes, she was given 2.5 milligrams of droperidol to treat her nausea and vomiting. Transport was initiated at 24 minutes, and a repeat set of vital signs show that she's still tachycardic at 105. She's more hypertensive at 197/97. Her respiratory rate 16, and her GCS is 15. They arrive at the hospital at 35 minutes. So getting an IV and obtaining serial vital signs are some places where we want to be doing and performing. Documentation was very minimal, and I find in just reviewing a lot of our urgent care or hospital or medical office visits that some of us document very little in that, and I don't know if it's just because someone else is already done the assessment, but either way, we should be doing our own physical exam and medical history obtainment and documenting as such. They placed a 22 gauge IV in a older female with pretty abnormal vital signs. Clearly probably not going to be hypotensive, but maybe at least an 18 gauge. And then the dosing of enapsine or droperidol was not appropriate for nausea and vomiting, which we'll cover in the next slide in a second. So in the emergency room, she had labs obtained. She got blood cultures. The doctor who took care of her told me that he kind of did a even more broad workup because of the fact that she was so obtunded, and he didn't know the dose of the droperidol that she'd received, but knew that she was pretty somnolent, and he thought it was related to the drugs that pre-hospital had given her, but wasn't sure if that was her underlying medical issue as well. He got a CT abdomen pelvis to evaluate her abdominal and back pain. The CT showed possible compression or end plate fracture of her lumbar spine. So we had a dedicated CT done, but in further review, she actually had recently been diagnosed with an L4 end plate fracture within the last couple of weeks. Her workup was significant for an elevated white blood cell count to suggest infection. Her lactate was elevated as well, and there were signs of possible urinary tract infection off of her urine analysis. After waiting a prolonged period of time in the hospital, she finally cleared, and she grew out bacteria with her urine culture. So I'm glad that we have all of our MPD group on this call. So in review of our vomiting and significant nausea protocol, the 2.5 dose is not the nausea vomiting dose. The dose is 1.25. So clearly that was why she was even more was obtunded in this case, is because she was treated with the agitation dose. And then that brought us to realize that the way our protocol is written, that it's not surprising where EMS believes droperidol is the drug of choice for nausea and vomiting, when actually it should be equivalent to Zofran, in that there are times where Zofran would be more appropriate over droperidol. And I would suggest an elderly patient, somebody maybe over the age of 60, maybe 50, depending on how you feel, you should consider using Zofran over droperidol, because our elderly folks tend to become more affected by droperidol than Zofran, and more affected either being hypoxic or altered over Zofran administration, and especially if you're using narcotics in addition to an antiemetic. So Zofran dosing is 4 to 8 milligrams, with the emphasis usually at 8 milligrams for our protocol, and droperidol should be 1.25. And I believe that we're talking about rewording our protocol so that it doesn't appear that droperidol is preferred over Zofran. It's equivalent, and I would suggest Zofran would be your drug of choice for your elderly or your patients that are also getting narcotics.
Agreed.
Perfect. So, yeah, go ahead.
Yeah, the trick is to word it in such a way that, and maybe we'll just do the simple way of reversing the order of the drugs, and then put or for all with droperidol.
Agree. I think that would be helpful.
And elderly persons, and I'm sorry, it is over 60 or 65. they do, there's a caveat in the general patient care is that in older persons, you're better off to use either the lowest dose possible or even to cut that dose in half. Even though I think 0.65 of droperidol is more likely to have more issues than not. And if you're anxious about older persons, just stick with the Zofran.
Mhm.
Now,
Awesome.
it sounds like this person did not get did not get anything for pain, correct?
That is correct. Nothing for pain, double the dose of Zofran. And I think maybe, I wonder, in this particular case, the medic had said they just made a dosing error, but I wonder because of Zofran being 8 milligrams in our protocol, I wonder if some crews might think that, well, if we can double up Zofran, maybe we can double up droperidol, but I hope that's not the case.
Yeah, probably not. It's a good thought though. Now the other thing with this person is she's also dehydrated, which is going to have much more of effect than just the volume and distribution of the droperidol, especially if you double the dose. It's going to be much more. They're going to have much more sedation.
Yeah, absolutely. All right. Well, if nobody has anything additional, I'm just going to do like a summary slide here. First box on the left is our hospice patients. These are patients that are usually terminal, end of life in the next 6 months, and that the care is directed at comfort, and that you always have the resource of the call center for the hospice group that patient's affiliated with to guide you if it's not clear what the goals of care or what would be tolerated previously discussed with the patient and the hospice team. DNR, living will, all of those are based on patient autonomy, if the patient has the ability, and then the hierarchy of who gets to make that decision if the patient can't make that decision. And as long as the patient is awake, alert, and has the capacity, just like the same criteria that we would use for refusal, they also have the option to change their code status. IGELs can ventilate just as effectively as an ET tube, and there are situations when you don't necessarily need to upgrade to an ET tube. And a reminder is that IGELs work effectively as a bite block. They can't bite through it. As a side note, I've had a patient bite through an ET tube fully, and that ET tube distally went down into their main stem. So ET tubes are not as safe as a IGEL for a bite block. And then droperidol for antiemetics, as a reminder to our last one, is that it is an option for nausea and vomiting. It is equivalent to Zofran. It is not preferred over droperidol, and especially in our patients that are elderly, that Zofran may likely be a better choice for them, and or so elderly and or that are getting narcotics, consider Zofran over droperidol in those circumstances.
Jackie, I do have one thing I want to add on the droperidol.
Yeah.
Which we discovered after looking at actually it was something I found when I was looking over the ketamine as a pain adjunct. I noticed that several of the medics were using droperidol prophylactically if they were going to give fentanyl or any narcotic, and that is not. I can see how it happened, but that is not to happen. You don't give anti-nausea medications, especially one that's a highly sedative, to people before they actually complain of nausea. This is not anesthesia, pre-hospital anesthesia. This is EMS medicine. And I can understand that we did find some discussion in our medication discussions in the back of the protocols that might have implied or might have been interpreted that that you could use this prophylactically to prevent nausea from fentanyl. That is not the case. That is not intended to be, and that is not in the orders. And we have cleaned that up now. The We only treat what we find, not what we're anticipating. Not everybody gets nauseated from fentanyl. By and large, most people do not.
Mhm.
Uh,
That's a good point. And it reminds me is that a person that develops hypoxia or altered mental status that affects their care or increases their level of treatment is considered an adverse reaction and a complication. And we really want to limit the complications that we provide our patients, especially if they are in some sort an iatrogenic produced by our care. So, I mean, if we find that all these patients are getting confused or hypoxic, needing supplemental oxygen, then it'll become more conservative. So we need to be mindful about the care that we provide and try to limit the adverse reactions to the patients based off of the care we provided.
Right.
Awesome. Well, thank you everybody for your attention. I know that this is a holiday week and that is, I'm sure you got thousands of things to try to multitask. If you have any questions, feel free to ask them now, or you can email me or the MPD group if you have anything that you wanted to bring up.
All right, thank you. And thank you everyone for being on, and have a great holiday.
Yes, happy holidays, however you celebrate them.